Hey everybody, welcome to another episode of the Global Health Impact Network. I'm Martyn Eeles. For today's episode, I'm not going to be hosting. We have a very amazing host who will be hosting this. You already know him by now. Ladies and gentlemen, please welcome Bob Sweeney, founder and principal of the Global Health Impact Network and the Global Health Impact Fund. Bob, it's a pleasure to have you with us.
Thank you, Martyn. Let me welcome everybody to this conversation. I'm Bob Sweeney. I'm the one of the co-founders of both the Global Health Impact Fund and the Global Health Impact Network. And I'm also the director of the Education Network for the GHIN. Today, I'm going to be talking to an individual I have a great deal of respect for, has a lot of experience in the hospital and healthcare industry as both an administrator and a marketer. Jeff Kline is the CEO of Hangenix. He's been there for several years. The company specializes in developing digital processes for dealing with hand hygiene. So with no more ado, let me introduce you to Jeff Kline. Good morning, Jeff. How are you doing?
Good, Bob. How are you?
I'm good. Can you tell us a little bit about your personal and professional background, and particularly how it bears on your getting into this aspect of healthcare?
Sure. So I grew up in Philadelphia. I was raised pretty much by a single mom who actually was a hospital microbiologist. So she raised me and my two siblings and had to work a lot of long hours in the laboratory. So as a young man after school, I'd spent a lot of hours in her lab doing my homework and incidentally learning a lot about viruses and bacteria and more importantly, infection prevention. It was something that she was very passionate about. And I think that's really what inspired me to pretty much pursue a career in the medical device space, which is where I've been essentially for the past 30 years. So I went to Penn State and started my career in medical sales, working for Baxter Healthcare for a number of years. And then after 10 years of sales, I got my MBA here at Emory. I was a consultant with Deloitte in their strategy and operations group for 4 years, and then went back into medical devices with a company called C.R. Bard, which is now a part of Becton Dickinson. And I did mostly corporate strategy and M&A work my first couple of years, and then I was head of their infection prevention portfolio for a number of years. So I essentially managed a $700 million P&L. And it was during that time when I had gotten contacted by the folks at Mass General's incubator, which is where our technology was developed. And it was from that initial contact that pretty much launched my career in pursuing this entrepreneurial endeavor with Hangenix.
So that's very interesting. Tell us a little bit about what the problem is. I mean, everybody knows you're supposed to wash your hands, but what's the practical effect of not doing that, and why do hospitals care a lot? I mean, it seems kind of obvious, but I think it probably requires, it's more than just on the surface.
Yeah, I mean, it's interesting. It's like now, because of COVID, there's not a person on the planet that doesn't understand the importance of hand washing. But, we went about solving a problem that's existed for generations, quite frankly, and that's reducing the mortality and morbidity associated with healthcare-associated infections. So when you look at the data, the number of deaths that take place from infections, if you look at both hospitals and nursing homes, it's close to 500,000 people die every year. So put that in context. We're at 620,000 deaths from COVID, and rightfully we're shocked at that number. Meanwhile, year after year, 500,000 people have been dying from what's mostly preventable infections that are taking place. So this has been a problem that hospitals have known about for a long time. The nursing home numbers have flown under the radar for a while, and the split is about $100,000 in hospitals, and 400,000 people in nursing homes are dying every year from infections. And a number of studies have shown that the number one cause of these infections is poor hand hygiene compliance. So people just aren't washing their hands when they're supposed to, and none of us believe that it's malintent, right? Everybody intends to wash their hands when they're supposed to, but they're busy, they get distracted, some haven't been trained as well. In areas like nursing homes, there's a ton of turnover. It's a lot of unskilled folks that are in there, certainly not trained in skills at the level of some of the registered nurses that are working in the ICUs of hospitals right now. So It's been a challenge forever. And, the biggest challenge is, management has got no effective means of actually monitoring who's washing their hands when they're supposed to. So the de facto standard that's existed and frankly still exists today is to use manual observation. So that means essentially, in hospitals, it's usually an infection prevention nurse, but over the last several years, the larger staff has participated in spending a certain amount of time during their shift observing their peers and essentially standing in hallways and watching the staff going in and out of patient rooms to determine if they wash their hands when they're supposed to. So you can imagine what a flawed process this is right now. It's broken for a lot of different reasons. I mean, number one, even the best of institutions committing a significant amount of money, they're not even capturing 0.1% of the hand washing opportunities that take place in the hospital. So, you can make what you want of that data, but it's certainly statistically insignificant when those numbers are rolled up. The next thing to consider is there's a Hawthorn effect. So the staff essentially knows when they're being observed, and naturally folks are on their best behavior at that point. So the numbers become skewed a little bit higher than what reality would reflect. And then there's naturally bias and error that take place when people do it. And then one of the bigger things is there's no specificity to the data. So at the end of the day, management will get a number that'll say we're 90% compliant. First of all, that's usually an inflated number, but they have no ability to kind of drill into that information to understand essentially who, when, where, and why hands aren't being washed for the most part. So in many ways, they're flying blind. And then the last thing I'll add to this, and before the next question, is a lot of the protocols for hand washing have been evolving over the past few years. So traditionally, and still in a lot of institutions, it's the protocol is that you need to wash before and after entering the room. They call it foam in, foam out in a lot of hospitals. And there were some studies that have been done that have found that over 80% of hand washing opportunities take place inside the patient's room. So you could wash at the doorway and then immediately go to the computer keyboard or go to the supply cabinet, and you've just contaminated yourself before you've gone to the patient. So the WHO and the CDC soon there followed with new guidelines that essentially, when you boil it down, says you need to wash your hands right before and after contact with the patient. So that's a very different paradigm at that point. And it ensures at the moment of truth, when you're about to contact the patient, that your hands are clean at that moment. And as we get into the conversation, I'll explain how our technology is able to address that, unlike anything that's on the market today.
Well, thanks for that overview, Jeff. As I understand it, the government in the U.S. at least, and presumably in other places, has begun to take an interest in this phenomenon because in the United States, a huge portion of healthcare is paid for by the government. Mm-hmm. So tell me what you can a little bit about that. And what do they require? What are they requiring, if anything?
So, this is another situation that's been evolving over the years. And, if we go back over a decade or longer, there was a time when actually infections were profitable for hospitals. So, the patients would stay in there longer and get additional treatment because of the infection, and the hospital would just get reimbursed for all that care. So, I'm not saying that, people were intentionally doing that at all, but they didn't have the incentives to actually combat these infections the way they do today. Now, fast forward, things have evolved so much where there's so many other factors involved, and it's part of one of the things, as we're selling our technology. Hospitals are a business, right? So you have to financially justify an investment in this kind of technology. So some of the things now that have contributed to the financial impact to hospitals, and I know that's part of your question, is that now there's a lot of penalties involved based on what infection rates are. So CMS, Medicare and Medicaid essentially are penalizing hospitals for having higher infection rates. So part of that reimbursement can be retained or held back from hospitals. And, depending on their patient mix, some hospitals, over half of their patients are Medicare patients. So even a couple percentage points on hospitals that exist on low single-digit margins, this is a significant financial impact. So it certainly was kind of a game changer a few years ago as that started to come into play. And then you look at things like pay for performance and, the concerns over, other types of infections that can really make an impact. There's certainly financial skin in the game. Joint Commission, obviously, is a body that's existed for a long amount of time. They are the quality organization that certified hospitals that often allow them to qualify to get Medicare reimbursement or other insurance reimbursement. Joint Commission has continued to kind of raise the bar year after year around the standards and what they're requiring of hospitals in order to maintain that accreditation that they need to get reimbursed out there. So, they're making sure hospitals have got to have a hand hygiene program in place. They've got to be measuring what their compliance rates are, and they have to be showing at least a minimum threshold or continuous improvement over time. What's interesting is if you look at the nursing home market, that had been pretty much an unregulated industry from an infection prevention standpoint for a long time. Now, COVID is beginning to change that right now. So now we're starting to see nursing homes getting quarterly audits from joint commissions, and now they have the ability to fine these facilities if they don't have the right programs in place. We're starting to see some folks lose their license now because of poor infection prevention practices. So the bar is getting higher and higher. External agencies are becoming more serious about that and putting more teeth in the penalties, and the financial implication of infections are getting higher and higher. And one other thing to add to the kind of the financial implications for hospitals, lawsuits for infections have been around forever and ever, and those continue to increase over time, and they can be significant burden of hospitals. And then one of the big things now is infection data is publicly available information. So a lot of hospitals make their profit on elective surgeries, your knee replacement or hip replacement. And in those situations, patients have a choice as to where they go for that procedure. And more patients are becoming educated and making their own decisions with this new transparency. So if you're going to get your knee replaced, aren't you going to go to what you think is the safest hospital out there? You don't want to get an infection after a knee replacement surgery. So all this, when you combine all this, the financial implications and the reputational implications for these hospitals, we're going to impact both the top and the bottom line of hospitals.
That's pretty interesting. So I would think, just listening to you and having thought about it before, that this would be that doing something about it would be a pretty competitive space. I would think that there's a lot of people with a lot of different approaches who are and would in the past have been trying to make the situation better. What is it? Tell us a little bit about your company, Hangenix, and about its products, so we have some idea about why you believe it is or why it is competitively advantageous.
Yeah, so you're absolutely right, Bob. So it's interesting. So this is a space where people have been attempting to address this through technology for at least a decade right now. So if we go back around that time frame, the early 2000s, companies like GE and IBM and some of the big data players, companies that back in the day had real-time location systems that were used to kind of track staff and track assets, a lot of them tried to basically bolt on a hand hygiene module to their technology. And those systems use radio frequency technology, RF. And they quickly found that based on, and I'll tell you the details about RF in a second, but what they found essentially is that RF was not going to be feasible on their platform for what they were trying to do. And within a couple of years, they exited the business because they didn't want to damage their brand out there, and they didn't want to have a product that created inaccurate data for the most part. So it's telling, the fact that big companies like that got into the space validates the fact that it's certainly a need that needs to be addressed through technology. What we've seen now over the past several years is RF, radio frequency, is still the predominant platform of a lot of our competitors that are out there. And let me explain the difference with RF and then our technology, which uses sonar or ultrasound technology. I'll explain the difference. So RF is a signal that is omnidirectional, and it goes through walls, and it's very difficult to contain. So if you were trying to do an application like tell me where the bed is or the pump is, and you want to know the general vicinity, then RF works well to do that. But when you get inside of a patient's room and there's a need to create a very defined zone, or in certain instances, multiple zones that may be next to each other, RF just completely does not work for the most part. RF, because it goes through walls and bleeds over, it sends up for inaccurate data out there. And that's some of what we've heard from a number of the competitors that are out there, which is why there hasn't been significant penetration in this marketplace for a while. So our technology, as I mentioned earlier, was developed at Mass General. So the two co-founders, Mike Dempsey and Ron Neubauer, both PhDs, a Harvard and MIT guy. They both have got scores of patents to their names. One gentleman worked for the asset tracking business, tracking surgical instruments, and he knew about the limitations of RF. And they looked at every modality. They looked at infrared, but infrared, you always needed a direct line of sight. They looked at GPS, but you couldn't get the granularity. So we landed on ultrasound or sonar technology, and that's where we have all the issued patents around the use of ultrasound. What's unique about that is ultrasound is actually a directional signal, and it reflects off walls, and you can practically shape the signal. So with our transmitters, we can actually create a very defined zone. And in the traditional applications, it's to create a zone around the patient's bed. So we put the transmitter behind the bed, and we might put it a couple of feet past the end of the bed. And this does a couple of things now, because now we can support the protocols that I had mentioned earlier, where you want to validate that people are washing their hands right before and after contact with the patient. Well, if you're using an RF technology, and at best you can just tell when somebody enters the room, but once they're inside the room, you don't know what they're doing at that point. So you don't know when they're within range of the patient or not within the patient. And are they making multiple contacts? There might be an opportunity where they need to wash their hands 2 or 3 times in one patient's visit, because they got the bedpan and they dumped it in the bathroom and they came back. Well, they got to wash their hands before they contact the patient again in that instance. So we create that zone using RF, and then we're able to put essentially a chip in any soap dispenser that's out there that is triggered when somebody washes their hands. And then we have a small, lightweight badge that the staff wears that's essentially tracking all their individual compliance data. So what happens is when they enter the room or they wash their hands outside the room at that point, they're given a time-based token. So the token from the soap dispenser on their badge basically sets a timer to a certain amount of time, and the hospital can determine that duration. It's usually around 30 seconds or so. So the staff knows I've got 30 seconds now where I'm considered clean and I'm free to approach the patient at that point. So when they approach the patient and they enter that protection zone, if it's been a couple of minutes or they never wash their hands, the assumption is that their hands are contaminated again. So at that point, they will get a reminder when they enter the zone considered dirty. And it could be an audible reminder, so it could be a beep or a chirp. It could be a visible reminder as a blinking red light, or it could be silent in just data capture mode, which a lot of times we do when we're training or establishing baselines out there. But it lets them know, hey, you need to wash your hands again. You forgot to wash, or too much time has passed. Then after they've cared for the patient and they leave the patient area, after a certain amount of time, they will be given another reminder if they fail to wash their hands at that point. So this is consistent with those WHO and CD guidelines that I'd mentioned earlier about making sure hands are washed immediately before and after contact with the patient. And then we essentially have data hubs, if you will, set up at the nursing station. So when the healthcare worker leaves the room, that signal reaches them and it pulls all the data from their badge and it ports it to the cloud. All this is done seamlessly at that point. And then we're pulling up that data, and we've got a database now where we can begin to send reports out to the various stakeholders in various formats, or we can tie it into their existing business intelligence tool, and we can generate reports through their package. So in essence, that's how our technology works compared to some of the RF-based technologies that we've seen out there.
Right. Now, you mentioned in passing nursing homes. So I'm imagining then that this technology or this approach can be applied in a variety of healthcare settings. Tell me a little bit about that.
This technology is applicable and is needed in several other industries. If we start within healthcare, nursing homes is a huge one, skilled nursing facilities. That whole segment, as I mentioned earlier, has been unregulated. And you saw a third of the COVID deaths took place in nursing homes. So it's certainly an area. And if the Delta variant has taught us anything, it's that, look, we're going to be battling this for a long time, if not forever. This will be something that will continue to be a challenge. So there's an even higher need to make sure that folks' hands are clean when they're caring for patients. But if we go out from there, dental practices, outpatient surgery centers, large physician practices, dialysis centers, and then we started to get calls from industries outside of healthcare. I mean,
Right.
think about it. You got food processing and the meat packers. You've got restaurants, manufacturing. And the data capture capabilities go beyond hand hygiene. But we'll stay focused on that for now. I mean, look, they want to know that their staff is following certain protocols, and look at the outbreaks that have taken place. We were even going to approach before COVID a lot of these poultry plants or the food processing plants. I mean, look at what the impact of like an E. coli outbreak is for these food companies. That's tens of millions of dollars in recalls that they're suffering. So there is a need to validate that people are washing their hands when they're supposed to in a number of different environments.
Have you had any, one of the things that we observed about the COVID pandemic, since you mentioned it, is that there's at least a measurable part of the public that pushes back against things that need to be done to improve the environment. Have you run into that in healthcare institutions?
Well, sure. I mean, this is, we view this as a change management project as much as anything. It's evolving. So in the early days when we were first getting started, when we did some of our earlier pilots, there was probably more resistance then. And it's interesting to see a correlation between the level of experience with some folks. So some nurses who've been around for a long time, they don't necessarily embrace change so much. And you're always overcoming kind of the big brother mentality. So folks are concerned that we're tracking them all over the place. Are we tracking when they're going to the bathroom and how much time they're spending? And there's a little bit of concern. I wouldn't say it's unjustified, but it's certainly not what's being tracked with this technology that's out there. Through COVID, a lot of that has waned. I mean, I use the term civil liberties. It's probably not the right term, but we've given up some level of freedom for greater protections out here in a lot of ways, right?
Sure.
You've seen the HIPAA laws soften a little bit. The use of telemedicine has expanded. And we're seeing that people are realizing, maybe I have to give away a little bit in order to have a greater protection, not only for me and our patients, but for the greater society in general. So we've seen that evolve. But, our big message when we go in and we meet with senior management here is to talk about look, you've got to be forthcoming with your staff about how this data is used. And we are vehemently opposed to using our technology as a punitive measure. We're not out there trying to catch somebody doing something wrong. And we've heard examples of people getting their pay compromised, right? Where they're because their compliance rates are so low that they're going to retain some of their bonus or things like that. We're like, no. This is not how this technology is going to be the most effective. We actually look at it the opposite way. Is that, we should be rewarding consistently good behavior or improving behavior over time. And that, this is data that the hospital has never had before. And I think a lot of the staff people, they want to know how they're doing, right? Because everybody has got good intentions and they just might not be aware that there's times that they're not washing when they're supposed to. So this is an educational tool. It's data. It can be used, we've even been with some hospitals that we've had some fun with, right? Where we've had units where at the end of the week, whichever unit had the highest compliance rates got a Starbucks card at the end of the week. So you're almost gamifying it in a fun way for folks. So a lot of these are the things that I think we can use to kind of overcome some of the resistance that's out there at the end of the day.
Well, while we're talking about that, I mean, I worked like you, for decades with medical groups and hospitals in one way or another. One of the things I discovered through experience was that it's a difficult decision-making situation. Hospitals are not like many corporations where you've got a structured hierarchy, and once you've decided to buy or do something, you can actually enforce it and get it done.
Mm-hmm.
Hospitals don't work that way. They have a distributed decision-making system, and that can make it longer to get things done and harder to get decisions made. Yep. So how do you deal with that? I mean, what's your experience with that?
I'm laughing because I've lived this challenge, like you said, for 30 years. So hospitals are tough. I mean, the sales cycles can be long. So, there's various ways to kind of work through that if you can. I mean, number one, our goal is to try to engage CEO if possible, or the C-suite here, because this is an issue now that's really bubbled up to, when I've looked at some surveys that are out there, interviews of CEOs, what are the top 5 issues that you're addressing? And infection prevention is very often up there in the top 5. So this isn't some crazy off the wall idea that's not going to get any attention from folks. So a lot of times, if we're able to get into speaking with folks in the C-suite, that helps. A lot of times that can expedite things, because they will identify the people that are going to be key to making the decision at that point. But I've also learned at the same time, you've got to have the staff that are going to be actually using the technology at the end of the day very involved early on in the decision-making process. Because, Bob, this, I mean, there's a couple factors. So it's getting the deal closed, and then it's maintaining the product in the hospital once it's in there. And if I've learned anything over the years, it's if nurses want your product out of the hospital, they're going to get it out of the hospital. I mean, they will find a way to undermine you or do something. So you've got to gain commitment from the folks that are using the technology, that there's something in it for them. Again, and this is to the whole, this is not a punitive tool. It's to help you do what you already intend to do at the end of the day. And, Corona, the COVID virus is also, forever, this was just viewed as a technology to keep patients safe. This is keeping the staff safe too. I mean, COVID is easily spread among staff, and also the fact that our badges can do contact tracing now is very helpful as well. But I think, identifying who are the champions and the ultimate decision makers in the hospital, I think, is key. And then, sometimes if you're able to work with certain partners that are in there that already have established relationships that can help get you to the right folks quicker, I think is important. But and another thing is, getting on the group purchasing contracts, I think is important as well, because that immediately can get you access to some of these hospitals right now through using those networks as well. And then you don't have to deal with overcoming the fact that you're not on the contract out there. But all that said, Bob, I mean, you're right. I mean, hospitals, even the best of reps and the best of circumstances, it can still be a 6-month sales cycle a lot of times for a deal of this magnitude, right? This is, this is not a sponge, right? There's a lot of people and a lot of stakeholders involved in this.
So that brings me around to thinking about where does your company stand? I mean, how are you doing? Where are you? What's your objectives in the next couple of years, and what do you have to do to get to them?
Yep. So, as this, for many years, this was a product development journey, right? So what we got from Mass General were the patents and really, really rough prototypes. I mean, I always love showing people the old samples of the badge that was like a brick that you needed to use a USB cable to manually download the data at the end of the shift. And then we had a soap dispenser transmitter that was the size of a cell phone that attached to the outside of the dispenser with a wire and a vibration sensor. So that's what we got to start with. with this technology. I mean, all that was obviously just a proof of concept, but it's gone through several iterations over the years, as you can imagine, and each one of the pilots that we've done in the early days was not about selling the product. It was about getting real life feedback in, the ICU or med surg units. You can do all you want in a lab all day long, but until you actually install it in a real environment and get feedback from staff, you have no idea how well the technology is working as well. So it's really was a 5-year journey to continue to pilot, iterate. And we did not want to come to market until we were very confident that this technology delivered on its promises, based on all that feedback that we've gotten from those pilots over the previous years. So we were all set to launch in early 2020. We had our first couple of paying customers teed up to install on early April, and of course, COVID hit. And these hospitals were in Florida, and this was in the hotbed of where COVID was taking place in the early days. And I mean, it's the ultimate in ironies, right? Everybody we talked to said, "Boy, I wish we already had this technology installed right now. This would be really helpful."
Right.
But when these hospitals are in triage mode and they're treating people out in the hallways and stuff like that, the thought of kind of doing an engagement like this, it's just too much for them to consider. So we really lost all of 2020 and what we expected to be revenue generating years. Was really a challenging time for us. But as I mentioned earlier, this is when kind of the light bulb went off, and as that door was closing, so many other windows opened up in all these other industries right now. So we spent the time making some modifications to the product even more in ways that would allow the technology to serve some of these other markets. So, the nursing homes and urgent care centers. So we've actually got 2 pilots going on in Dallas right now, one in a skilled nursing facility and one in a chain of urgent care centers. So that's another area. It's the fastest growing segment in healthcare right now. And certainly they're concerned about COVID and keeping people safe, and the technology will certainly help with that. But it's also, they are trying to communicate to the marketplace that, look, this is a safe place to come. And it's better alternative than going to your emergency room or waiting a couple weeks to get in and see your primary care physician. You can come in here right away. So they need to convey to the public that it's a safe place. So there are a lot of them. The guy in Dallas is using our technology in the way he promotes his company by saying, "Hey, look at the investment we've made in technology to keep you safe and to keep our staff safe that are out there." So, and we saw about the first quarter now, hospitals have started to soften up, and we're starting to see a higher demand. If it wasn't already on hospitals' radar before that they needed to address this, it certainly is now for the most part. Now, what's frustrating is Delta's coming back now, but again, it's like COVID in the first place. It's gonna cut both ways. So there will be certain areas where we're gonna have a hard time getting in again right now. I don't believe that this is gonna be anything like the first wave. I think within a month or two, we're going to see the number of cases start to come down again. And we'll certainly have the ability to have access to these hospitals. We have a number of sales cycles in place right now. But as I mentioned at the top of our conversation, I think it's a reminder. Delta is a reminder that it's not going to go away. And now is the time to invest in these technologies. That's just another level of assurance or another level of making sure that we're keeping the patients and the staff as safe as possible. So, we're at the point now where we're also, we're continuing to raise capital because we want to be prepared to move quickly. I mean, we think things are moving fast. Once we get these pilots wrapped up, I really think the nursing home market is it's significant. It's larger than the hospital market is, and I think the need is just as much in that environment as it is in hospitals right now. So we're going to really be aggressively going after the nursing home market. And again, the hospital market is one we're going to work with. So we recently signed a distribution agreement with Henry Schein. So they are the largest medical distributor outside of the acute care hospital space. So all these markets that I mentioned around outpatient surgery centers and large physician practices and urgent care centers, that is in the the bailiwick of Henry Schein. So we're going to be doing some targeted launches with them in the Georgia area and then in Texas, where our technology team is based. So we'll be pairing up with their sales folks there and really aggressively going to get some early engagements, some pilots, some paid pilots in some of these different segments we mentioned earlier. And then the plan is, toward the end of the first quarter, we'll open up to more of a national scale. So, we're going to need to raise more capital in order to have the infrastructure to support some of our aggressive sales goals that we're targeting for 2022 and beyond.
All right. Well, all of this has been very interesting to me, and I'm sure to many of our audience. Can you think of any topics that are important that we haven't touched on, or anything else that you want to add here?
Well, yeah, I'm glad you asked. So what's interesting about our technology is, so number one, we view our company as a data company. And number two, we view our technology as a platform technology. So this isn't a single application, it's just monitoring hand hygiene. What's really unique about this technology, as I mentioned, is the fact that we can create these very defined zones. So it allows us to capture a lot of data. If we just start looking within the health organization, hospitals are using data constantly, and the better hospitals are more sophisticated in the predictive analytics that they're doing and the AI, and they're constantly looking for sources of data. I mean, some of the things that we can track with our data, we can certainly do time and motion studies with our technology. We can track how much bedside care time a physician or nurse is spending with a particular patient. So, a couple of reasons for that. Number one, there's a correlation between patient satisfaction and the amount of time the physician spent bedside with the patient. So they can track that. But a lot of hospitals are starting to move to activity-based costing, and they want to allocate physician time specifically to a patient while they're there. So that allows us to do that. We can track the environmental services folks that are cleaning rooms, so we can validate are they going to the rooms that they need to. But more importantly, how long does it take for them to turn over an ICU room so we can bring in another patient at that point? As I briefly mentioned, we can do contact tracing with our badges. So if anybody ever contracts COVID, we can run a report and immediately tell you everybody that's been within 6-foot range of them over the past couple of days at that point. So it automates the process of contact tracing along those lines. And that can work with any kind of outbreak, C. diff or any of the other ones, MRSA. It allows us to track that. So, and this data capture capability is going to go well into industries beyond that. So I'm saying all this not to say we're going and chasing all of these things right now. We're a startup, right? We got to be focused on the primary application of the technology. But the long view of this technology is when we get the infrastructure in place in organizations, we have the ability to capture so much more data than just hand hygiene. That is really exciting for us.
Well, thanks. I appreciate your giving us that additional insight.
Yeah.
Well, I've enjoyed it, Jeff. It's always good to hear from you because you articulate the issues so well.
Thank you, Bob.
We'll provide some contact points so folks can directly reach you if they want to at the end of the recording here. And I thank you once again for your time and willingness to share this information with us.
Great. Thanks, Bob. I enjoyed it.
Bob, Jeff, thank you so much. That was a very amazing talk. I really appreciate it. I hope the listeners really enjoyed it. Again, I'd like to thank everyone who listens to these episodes. It really means a lot to us. And I hope you tune in next week for next week's episode. Stay safe, stay healthy. Bye-bye.